Hello everyone. Today we will be talking about heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia is a severe complication that can occur in patient who has been exposed to any form or amount of heparin products. So it is basically characterized by two things. As the name itself suggests, it is thrombocytopenia, that is the decrease in the platelet counts, and also a hypercoagulable state. So there are two types of heparin-induced thrombocytopenia. First is the type 1 heparin-induced thrombocytopenia, also called as type 1 HIT. It is also known as heparin-associated thrombocytopenia. It is non-immune mediated reaction. It is much more common than type 2 and can occur as early as day 1 of therapy. And this is a very mild reaction and it is not associated with any complications, and platelet counts will spontaneously normalize even if heparin is continued. However, the type 2 HIT is a immune-mediated thrombocytopenia, and it usually occurs on day 5 to 10 days of therapy, and it is a severe reaction, and it does not normalize if you can keep continuing heparin. So as I said, type 2 HIT is an immune antibody-mediated reaction, usually occurs on 5 to 14 days of receiving heparin. However, if a patient has been exposed to heparin within the last 100 days, antibodies may remain in the system, causing this reaction to manifest as soon as the day 1 of re-exposure to heparin. So that means that if a patient has been exposed to heparin in last 100 days, and again if he is exposed to heparin now, he may develop HIT type 2 HIT on day 1 itself rather than on day 5 to 14 days. This is a very serious reaction that causes a hypercoagulable state and can lead to life-threatening complication. So how it causes hypercoagulable state, that we will be discussing later. So pathophysiology. So under normal physiological condition, what happens is there is a factor called as platelet factor 4, which is present and which is stored in alpha granules of the platelets. So this is the platelet factor 4, which is present in the alpha granules of the platelets. On activation of the platelets, these alpha granules are released into the system, and this gets attached to the heparin or heparin sulfate in the normal endothelium. So when the patient is exposed to heparin, this platelet factor 4 is released on activation, and this platelet factor 4 binds with heparin here, heparin and platelet factor 4. To combat this platelet factor 4 and heparin complex, immunoglobulin G is released to form the immune complex. This immune complex is combines when it lead. What does this immune complex do? It activates the more platelets, and which leads to platelet aggregation. So it causes activation of the platelet release, and platelet aggregation. So more the platelet aggregation, more will be the chances of thrombosis here. And also, as there is more amount of platelet aggregation, the platelet gets accumulated in this form of thrombus, and thus there is thrombocytopenia. Also, this impaired platelets on activation, which is attached to this complex, is gets removed by the splenic macrophages, which also leads to thrombocytopenia. So thrombocytopenia is basically because of two things. One is because of the consumption by the splenic macrophages, and the other thing is because of the platelet aggregation, which itself leads to decrease in platelet count. So that's how it causes the hypercoagulable state. The most common complications of this hypercoagulable state is deep vein thrombosis, pulmonary embolism, or skin necrosis. However, it can also cause arterial thrombosis. The first step in the diagnosis of HIT is the calculation of the 4T score. So this score is important. It basically consists of four components. That is the time, amount of thrombocytopenia, the points are given as 2, 1, and 0. Timing of platelet count fall. When does the platelet counts actually start falling after the exposure of heparin? What are the thrombosis or other sequelae, if it is any there or not? And other cause of thrombocytopenia, if it is apparent, possible, or definite. So based on that, the score is given based on these four factors, 4Ts, the score is given. The total score is 8. So a 40 score of 0 to 3 means that HIT is very unlikely and the patient can be continued on heparin. A score of 4 to 5 corresponds to intermediate probability, and score of 6 to 8 means high probability of HIT. On evaluation, all forms of heparin. So whenever you suspect a heparin-induced thrombocytopenia, all forms of heparin, including line flushes, should be immediately discontinued, and treatment with an alternate anticoagulant should be pursued in any patient who scores 4 or more. So whenever you suspect a heparin-induced thrombocytopenia, when you see a thrombocytopenia in the patients who are exposed to heparin, you have to calculate this 40 score, and if this score is more than equal to 4, you have to stop all the heparin, and then you have to send for platelet factor for ELISA and serotonin release assay, which is the confirmatory test. So PF4, platelet factor 4 ELISA is an immunoassay that detects the presence of antibodies. This test is highly sensitive, but it has poor specificity. That means that if the test is negative, it has a very high negative predictive value. That means if the test is negative, it can be absolutely ruled out. But if it is positive, it does not mean that it is hit. It can be other causes as well. So it has high negative predictive value. So the treatment of HIT should start as soon as the 40 score of 4 or more is calculated. As I've already discussed, the score is 4 or more, you have to start the treatment of HIT. The first treatment of that is you have to stop the heparin. Next, an alternate anticoagulant must be initiated to prevent or treat any HIT-induced thrombosis. So as I've already discussed, that HIT itself can cause thrombosis because of the activation of platelet which causes thrombosis. So you have to start on alternate anticoagulant, otherwise this thrombosis may lead to life-threatening conditions. So when patient who has recently started on warfarin should be withheld and vitamin K should be administered to replete the protein C and protein S stores. So warfarin, if a patient is on warfarin for any some indication, warfarin should only be started once the platelet count has normalized. So according to the 2018 American Society of Hematology guidelines, an alternative anticoagulant must be initiated at the therapeutic intensity in vast majority of patients. So in which patient you should start an alternate anticoagulant, there are the indications which have been given. That patient, any patient with a high probability, that is a 40 score of 6 to 8, who have to start them an alternate anticoagulant. Suppose a patient has intermediate probability of 40 score, that is 4 to 5, but has another indication for any therapeutic anticoagulation, you have to start him on anticoagulation. So any patient with intermediate probability 40 score, that is patient has a 4 to 5 score, but there is no other indication of therapeutic anticoagulation, but the bleeding risk is very much low, you can still start them on anticoagulation. Prophylactic dose of an alternative anticoagulant may be initiated in a small subset of patients who are considered to be at high risk of bleeding. So provided they do not require therapeutic anticoagulation for different indications. So suppose a patient is requiring, if a patient has a intermediate probability score, but he is at high risk of bleeding, you may start him on prophylactic doses. So once the patient has been started on prophylactic doses, if on further testing, that is the serotonin release assay and on platelet factor 4 assay, if those tests comes positive, you have to convert them into therapeutic anticoagulation. So what are the treatment drug which you can use? The other anticoagulants and you can use is the direct thrombin inhibitors like bivalirudin is a drug of choice. Though the chances of developing heparin-induced thrombocytopenia with low molecular weight heparin is lower than with conventional heparin, low molecular weight heparin cannot be used after the onset of heparin-induced thrombocytopenia. So other anticoagulant which you can use is fondaparinux or a direct oral anticoagulant. So on summary, there are two types of HIT, that is type 1, type 2. Type 1 is non-immune mediated, type 2 is immune mediated. It is more common, that is 10 to 30%. This is less common. It usually occurs on day 1 to 4 of initiating heparin. This occurs on day 4 to 16 of initiating heparin. There is a mild thrombocytopenia. There is moderate to severe thrombocytopenia. Complications are none, but it can cause life-threatening thromboembolism. Management is observation in type 1 HIT and anticoagulation in type 2 HIT. Hope you have liked this video. If you want more video like this, do subscribe to my YouTube channel, Dr. Akif Baig. Thank you.